Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Sangeetha Balakrishnan. Dr. Balakrishnan is an internal medicine physician and cardiologist.
Hi everyone. Thanks Archana Bindra for the nice introduction. As she said, I'm Sangeetha Balakrishnan. I'm a cardiologist here at the Washington Hospital Foundation, and I have been in practice since 2011. They've asked me to talk to you about heart health and diabetes. What is the connection? So to start things off, in just general terms, what is diabetes? Diabetes is a disorder of metabolism. It's a prolonged state of elevated blood sugars, a fancy term we label as hyperglycemia. Usually sugar is released into the blood after digestion. Insulin, a hormone made by the pancreas, helps the glucose enter the cells throughout the body. So two main types of diabetes. Type 1 is the body does not produce enough insulin. Type 2 is the body produces insulin but doesn't use it very well. So just a picture describing, the two types. The first is just a healthy pancreas, healthy body with the pancreas releasing insulin. This is the cell, one of the cells in the body. It has an insulin receptor. It has a glucose channel or sugar channel to allow the glucose or sugar to enter. So what naturally or usually happens is insulin goes and attaches to this receptor on the cell. Once it attaches, the glucose channel opens up and allows the glucose or blood to enter the cell. In type 1 diabetes, the pancreas is not producing any insulin. Nothing is attaching to the channel or the receptor, and the glucose can't enter the cell body. In type 2 diabetes, there's a lot of insulin sitting around right here, and there's a lot of glucose, but for whatever reason, the receptor isn't recognizing the insulin molecules. So even though the glucose or the sugar molecule is attaching to the channel, it's not entering the cells. So the end result is you have glucose coming into your blood, or sugar entering your bloodstream, insulin being released into the bloodstream, and nothing is entering the cells because of the insulin resistance in type 2 diabetes. That's the general gist of type 2 diabetes. So this is what we're measuring when we're saying, are you a diabetic or do you have prediabetes? We're measuring, for now, fasting blood sugars. So if your blood sugar is fasting less than 100, you're okay. If you're in the 100 to 125 range, you're in the prediabetes range. And if your fasting blood sugar is greater than 126, you're in the diabetes range. So what happens in diabetes and heart disease is, heart disease is any disease that affects the heart, that narrows the blood vessels, that restricts blood flow to the heart or other heart-related organs. Diabetes, as we just said, is the high level of sugar in the bloodstream. So what ends up happening in diabetes is you have these high amounts of sugar in the bloodstream that leads to the walls of the arteries getting more sticky. The sugar just causes inflammatory cells, inflammatory markers to come into the blood vessel, and they all deposit right along the blood vessel and cause plaquing, cause calcium deposits. So this is your normal heart artery. You see, unrestricted blood flow. And in a diabetic artery, this plaque is restricting or diminishing, decreasing blood flow. So in diabetes, the artery tends to increase plaque formation at a greater, faster rate, which also consequently leads to it affecting nerves. So the blood vessels are supplying certain nerves in the heart, or legs, what have you. As the blood vessels become diseased, so does the nerve that those blood vessels supply. And we see a lot of this in the feet, and patients have what we term neuropathy. They get numbness or burning in the feet because of this. So reduced blood flow also leads to reduced or increased nerve damage. So if you have diabetes, the statistics say that you are 2 to even up to 4 times more likely to die of heart disease or stroke. Most type 2 diabetes, diabetics go without knowing that they have diabetes, or it goes undiagnosed for many years. Initially, you're not going to have any symptoms. If you're in that pre-diabetic range, you might have a little bit of fatigue. Early diabetes, you might have a little bit of fatigue, but unless we're actively screening for it or paying attention to symptoms, this tends to go undiagnosed. There are over 300,000 annual heart attacks as a result of in patients with diabetes. It leads to increased risk of micro and macrovascular complications, which means, micro means, the arteries supplying the eyes, all the little arteries, micro, and then all the big arteries, the macro, those that supply the heart and the brain. So it increases the risk for those type of complications. And you're at 60% or greater chance of dying of heart disease if you're a diabetic than if you're not. So, these numbers are scary. So what encompasses cardiovascular disease or atherosclerosis? As you can see from the pictorial here, blood vessels supply every part of the body, the brain, the heart, legs, kidneys are in there. So when the arteries have plaque formation and decreased blood flow because of the narrowing, clots tend to form, what we call thrombosis or clot, and they can occlude those arteries that supply all these organs. So if it blocks the brain, arteries in the brain, you have a stroke. If it blocks arteries in the heart, you have a heart attack. Diabetic patients have increased risk for kidney failure and kidney disease because it affects the arteries that are going to supply the kidneys. You have what we call peripheral vascular disease, where the arteries supplying the feet and the legs have decreased blood flow, and you have symptoms like claudication, which is signs of pain in your calves because the arteries in the feet aren't getting enough blood because of this atherosclerosis. So what can we do? We can't, some things are out of our hands. We can't change genetics. We can't change, the fact that our father or mother had diabetes. We can't change our age, but there are other things we can change. Weight, your activity level, cholesterol, your blood pressure. So a way to be smart about your heart is to control the ABCs of diabetes. A standing for the hemoglobin A1C, which we'll review, blood pressures for the B, and C for the cholesterol. So what is hemoglobin A1C? Just in general, it's the average blood sugars that your body sees over a 2 to 3 month period. The amount of glucose, it's basically, hemoglobin is a molecule inside red blood cells that carries oxygen. And when there is a lot of glucose sitting around in the blood vessels, some of that glucose goes and attaches to that hemoglobin molecule. And we measure that with the hemoglobin A1C. So going back to our previous fasting blood sugar criteria, the hemoglobin A1C criteria is, normal is less than 5.7. You're in the pre-diabetes range if you're 5.7 to 6.4, and you're a diabetic if you're greater than 6.5. So once you have the diagnosis of diabetes, your goals of hemoglobin A1C changes a little bit. For most patients, we target a hemoglobin A1C of less than 7. For younger patients who haven't had diabetes for a long time, where you can be a little more stringent, we can target hemoglobin A1Cs of 6.5. For patients who have had diabetes for a long time, who have had a history of hypoglycemia, where low blood sugars, and have had symptoms from that, we tend to be a little less stringent and target hemoglobin A1Cs of less than 8. There is some data that shows that the Mediterranean diet helps in diabetes control and cardiovascular risk in diabetes control. And in a sense, the Mediterranean diet focuses mostly on centered around vegetables, fruits, whole wheat grains, plant oils like olive oil, beans, seeds, using fish and seafood for your animal protein, less chicken or poultry, eggs, cheese, yogurt, and even less red meats and sweets. So that's a good diet to think about when you're a diabetic and we're trying to reduce our cardiovascular risk. Next, on our ABCs, the next thing we want to control or figure out is blood pressure. Blood pressure consists of two numbers, the top number, which is the systolic number, and the bottom number, which is the diastolic number. The systolic number represents the pressure on the arteries when the heart pumps blood. The diastolic number represents the pressure when the heart is resting. In patients with diabetes, about 4 to 80% of diabetics have hypertension. Diabetics are 2 times more likely to develop hypertension. Once you have both diabetes and hypertension, your risk for, like we said, kidney disease, renal disease, increases by 70%. There's the prevalence or risk of having both in patients hypertension and diabetic, you'll have renal disease. In patients with both have increased risk of retinopathy, which is diseases of the eye. With relation to heart, diabetic and hypertensive patients are three times more likely to have heart disease, 2 times more likely to have LVH, which is basically hypertrophy or thickening of the heart muscles, because the heart is pumping against higher blood pressure, and so it's a muscle, it's going to thicken as it's trying to work harder. They're 3 times more likely to develop CHF or certain types of heart failure. Diabetics and hypertensives have increased risk, as we talked about, for peripheral vascular disease, but if you have hypertension added to the diabetes, you're at even more increased risk, and the proportion increases with relation to how well your blood pressure is controlled. And then, as we said, we talked about your increased risk of stroke. So what are the normals in blood pressure? Less than 120/80, you're in the pre-hypertensive range. When you're 120 to 139 systolic, 80 to 89 diastolic, you're in the high blood pressure range, 140 to 159. And 90 to 99. As you can see, the higher up you go, the more alarm you should have about trying to control your blood pressure. So the goals in diabetic patients for blood pressure in general are to be less than 140/90 for most patients. And for young patients or patients with certain type of other risk factors, such as if you're a smoker, if you already have been diagnosed with high cholesterol, family history of heart disease, or discovery of protein in your urine, we might target lower blood pressures, less than 130/80. This is very individualized. Some studies are saying lower the better, but you also have to weigh the risks and benefits of the side effects of some of the blood pressure medications, especially in our older patients. As you get older, you're more likely to have the side effects from blood pressure medication. So individualizing goals is important. There is a diet, just like the Mediterranean diet, the DASH diet has been shown to help with controlling hypertension. Essentially, it's similar to Mediterranean diet in that it focuses around fruits and vegetables being your primary servings, and using whole grains and seeds and nuts, and reducing the intake of saturated foods, sweets, low dairy, low-fat dairy. Another part that affects blood pressure is sodium, excess salt. 9 out of 10 Americans consume too much sodium. It comes, in the foods that we buy, processed or prepackaged foods that we buy at the supermarkets, when we are out eating in restaurants. Americans tend to have, on average, 3,400 milligrams of sodium intake daily, and the American Heart Association recommends about 1,500. So we are taking in a lot more sodium than we should, and it has the adverse effects on high blood pressure. And just to kind of reinforce the point, I have patients come in and say, "Doc, I don't add any salt to any of my foods. It's nowhere even near on my table. I'm not physically adding." But it's already added for you when you're buying breads and rolls at the supermarket, cold cut meats, the pizza that you eat at the restaurant, pre-prepared meats, soup. A canned soup has a significant amount of salt already added. So just being aware of what you're eating. You might think you're not adding salt, but it's already there. So just having that awareness. So this, in the ABCs of diabetes, the C is for cholesterol. So cholesterol is a substance made by the liver. It is actually important for us. It makes up cell membranes. It helps make hormones. It's in our bile acids, what helps with digestion. So it also comes from our diet, foods rich in saturated fats, trans fats, simple carbs. These contribute to the liver producing more cholesterol. It's transported mainly in two main ways by proteins, the LDL low-density protein and the HDL high-density protein. Low-density protein, quote-unquote, the bad cholesterol, it carries cholesterol from the liver to the blood. Cells extract the fat and the cholesterol and use it for their daily functions. But when there is too much cholesterol in the blood, it can deposit and form the plaques that we're talking about. Too much plaquing narrows the blood vessels, limits blood flow. And when the plaque breaks off, you have the heart attack and other consequences of plaque formation. So LDL levels, optimum is less than 100. Near optimum or just above optimum is 100 to 129. Borderline high, 130 to 159. High is 160 to 189. Your HDL, which is known as the good cholesterol, it picks up cholesterol from the bloodstream, from LDL artery walls, and delivers it back to the liver. Ideally, the higher the number, the more heart protective it is. If you're less than 40 for men and less than 50 for women, it tends to be actually a risk for heart disease. So the higher it is, the better. So bad versus good cholesterol. Just as you can see, the yellow is the LDL lining the heart arteries and causing plaque formation and blockage, while the green is kind of picking up, the HDL is kind of picking up and trying to deliver it back to the liver. Third part of your total cholesterol that we pay attention to as well is your triglycerides. It's another type of fat that is used as energy source in the body. It's made from excess calories and stored as fat. It's included in the total cholesterol score, and it also contributes to atherosclerosis and risk for heart disease and stroke. So you eat the sugars and the fats in your diet that some of it is spent, as energy, and the leftover is converted to triglycerides and stored as excess fat in your body. So the numbers we look for triglycerides, we ideally want you to be less than 150, borderline high, 150 to 200, very high, we don't like it if you're above 500. So goals of cholesterol in diabetes patients. Again, this should be individualized per patient between you and your doctor, but most diabetic patients should be on a cholesterol lowering agent as a statin, which are a specific type of cholesterol lowering agents. We used to target specific numbers in patients. Now we're trying to incorporate more patients based on risk factors, and we believe diabetes to be, or we treat diabetic patients as if they've already had their first heart attack. So we try to be as stringent or as aggressive about lowering cholesterol as we can. And it sometimes just doesn't matter about specific numbers. It's also about decreasing inflammation that isn't necessarily measured on the cholesterol numbers. So I say most diabetic patients should be on a statin if there's no other contraindication. So what helps with cholesterol? There are the good, the bad, and the ugly facts about fats. So monounsaturated and polyunsaturated fats, they can lower bad cholesterol levels, and these mainly are the plant-based liquid oils, nuts, seeds, fatty fish, such as olive oil, peanut oil, canola oil. Good fish are, trout, salmon, the fatty fish. Seeds, walnuts, sunflower seeds, avocados. These are all good sources of good fats to incorporate in our diet. Things to limit are the saturated fats, and these are more from animal sources, the butters, coconut oil, palm oils, whole milk cheeses. Things or fats to avoid as much as possible is the hydrogenated oils and the trans fats. The partially hydrogenated oils had been used to extend the shelf life of a lot of our pre-processed foods on the shelves. A lot of manufacturers are moving away from it, but it's important to pay attention to the labels, the nutrition labels, and make sure that you're trying to avoid the partially hydrogenated oils and limiting your intake of baked goods and fried foods. And then there's a difference in terms of the type of carbs you take in, simple versus complex sugars. The simple sugars are digested quickly and increase your blood glucose levels, such as the white rice, the white bread, the white pasta. If you move over to the complex sugars, such as whole wheat bread, whole wheat pasta, brown rice, they're better for you. They provide more nutrients and minerals, and they have slow release of the sugar, so slow increase in your blood sugar levels. So, try, as we talked about for salt, we also want to try to limit our added sugar intake. Sugar-sweetened beverages are the biggest source of added sugar in the American diet, along with cakes and muffins and cookies. So ideally trying to replace soda with water or unsweetened tea or sugar-free beverages. Instead of reaching for the cupcake, reaching instead for berries or fruit. I'm not saying, avoid sugars completely. I mean, we all have to live a little bit, but trying to limit the intake. And I say the ABCs of diabetes. There is that S part of the ABCs, and that is stopping smoking. If the benefits of quitting smoking, I tell my patients, if there's one thing you can do that will impact your health the greatest, is quitting smoking. If you just, you see, these are some of the benefits. 20 minutes after quitting smoking, your heart rate drops. 3 months, your lung function, your breathing begins to improve. A year after, your risk of heart attack drops sharply. Your risk of stroke reduces in 5 years. So huge benefits from stopping smoking. Another risk factor that we watch for is keeping a healthy weight. We pay attention to your body mass index. It gives us an overall estimation of body fat. As the BMI increases, your risk for cardiovascular disease, hypertension, the diabetes, gallstones increases. And it's important also to know where the fat distribution is. If you have fat in the belly, you're at more increased risk of having heart disease than body fat somewhere else. And the way we measure BMI is based on your weight and your height. And ideally, we want less than 25 for an ideal body weight, 18 to 25. Switching gears, incorporating exercise into our lifestyle. Exercise and diabetes, it reduces not only your weight, it improves blood sugar control, it reduces the doses of some of the diabetic medications you have to use. And in general, huge benefits with exercise, improves mood, decreases blood pressure, as we talked about, decreases stress, improves your memory, huge benefits. So the American Heart Association and the American Diabetic Association is similar recommendations, but the AHA recommends at least 30 minutes of moderate intense activity 5 days per week, or 25 minutes of vigorous activity 3 days per week. And also to combine it with some degree of resistant training or resistant activity, muscle strength activity, about 2 days a week. Also, sleep is very important in our overall heart health. Sleep deprivation increases risk for heart disease, increases our stress levels, blood pressure, stroke. The American Heart Association recommends 6 to 8 hours of sleep. The ways to improve sleep is if you're exercising regularly, your body's tired, you're going to fall asleep. Avoiding too much caffeine near bedtime, and having a bedtime ritual, a soothing tea, bathing. reading a book. So what are we trying to prevent are the heart attacks. What are some of the, just briefly, some of the signs of a heart attack? Chest discomfort, irregular heartbeats, sometimes stomach discomfort, shortness of breath, sweating. Women still have the same, chest pain is still a common or most common side effect of, not side effect, a symptom of heart attack, but they also have other atypical symptoms such as fatigue, back pain, anxiety, sleep disturbances, nausea. So it's just important to pay attention to changes in how you feel, you know, if you're a woman. 45% of all heart attacks represent silent heart attack, and diabetics, if you remember, we talked about how diabetes affects the nerves. So some of the nerves in the heart are also affected by the diabetes and nerve damage. And so you're not going to have sometimes the typical chest pain that other people would have if you're a diabetic. So it is important to maybe pay attention to that fatigue. Am I feeling different? Am I more short of breath than I had been, you know, going up the stairs? So symptoms aren't always going to be classic in diabetic patients. So what entails a heart attack? There are three main blood vessels that feed the heart. So you see the plaque build up on one of the blood vessels. It prevents blood flow and can lead to dead heart muscle. Typical workup is medical history, physical exam, doing an EKG, checking blood work to see if certain enzymes have been released because of the heart damage, getting an ultrasound of the heart, possibly doing a stress test. Procedures like heart cath, which looks for the plaque in the arteries. A way to, if they do find it, a way to fix it is kind of ballooning open the plaque, placing a stent so that that plaque kind of stays to the sides and the artery stays open. Stroke is another, as we talked about, a complication or you're at increased risk. And these are the arteries that feed the brain. If they have plaque formation in the artery, that plaque can travel to the actual brain blood vessels and cause stroke. The mnemonic is be fast. You should be thinking about if you have changes in your balance, sudden change. If you lose, vision in one eye, or you have blurry vision or changes in vision, you feel, one side of your face being weak or uneven, the arm being weak or, drops to the side. If you have slurred speech or confused speaking, then you should, immediately call 911 and get checked out. And time is, as in heart attacks, time is of the essence. You might be eligible for, getting clot busters if you show up in time and decrease the complications of stroke. And then peripheral vascular disease, as we've talked about, the arteries that supply the legs. If they have a blockage, you can have pain that we termed claudication. Other symptoms are having pain while you're walking, pain that tends to stop when you rest, numbness, tingling, weakness in the legs. If you have a sore in your leg or foot that won't heal, cold legs or color changes are all things to kind of pay attention to in most patients at risk for peripheral vascular disease, but especially in diabetics. And a screening tool we tend to do to look for peripheral vascular disease is simple enough, just comparing the blood pressures in the arm versus the leg, screening for a peripheral vascular disease that way. So in summary, diabetes, a condition where there is too much glucose or sugar in the blood. People with diabetes are 2 to 4 times more likely to have heart disease, a heart attack or stroke. And essentially it's because diabetes speeds it up. It speeds up the plaquing and puts you at increased for completely blocking those arteries that supply all the different parts of the body. And as we said, the ABCs of diabetes, knowing them, controlling them, the A1C, the blood pressure, the cholesterol, stopping smoking, losing weight, getting exercise, eating well, and being compliant with your medications. Okay, thank you guys.